I presume that was a good introduction, Chava, so I thank you for that. I'm sorry I have to give this in English. My brain is mature, and so it's much harder for me to learn things, although I keep on thinking, because I come to Israel so often, that I really should go on an intensive ulpan and learn Hebrew. So for those of you whose English isn't all that good, I promise you it's much better than my Hebrew. So I've got a vocabulary of about 200 or 300 words, but I can't string them together to make sentences. Before I start, I just want to congratulate you. And, Chava's been telling me about this course and how successful it's been. But I just want to acknowledge the commitment that you people have shown to come every single Wednesday from all around the country. And not just that, but you pay money to come as well. So that's a real commitment. And I'm sure you don't come only for the food. So I made a video for the Milchedet conference, and I called the people in that meeting Chalutzim. But you're Chalutzim as well, in a way, because I think you're the forerunners of what I know Chava hopes and we hope will be a very different way of practicing children's health. So what I want to do today, this could have easily been the very first talk in your seminar series, but instead it's towards the end. So it'll sort of sum up, if you like, the rationale or some of the rationale for why this course has been put up in the first place and why you're coming to attend every time. Are you all comfortable with my English and my pace of things? So if you want explanation or I'm going too fast, please just interrupt me and I'll slow down or I'll answer your question. So these are the themes that I want to cover in my talk. One is that prevention is better than cure, and from a public policy point of view, it's certainly much cheaper. And that's why Milchedet's interested in this, because the business plan is if you can intervene and prevent problems or intervene at a very early stage, it ends up being much, much cheaper. But early intervention, the research is really clear now, and I'll show you some of the evidence. Early intervention in the early years of a child's life presents more serious problems right through the life course, not just in children. I'll show you there's a very robust body of research now that says a lot of problems in adults start in those early years, even before a child begins school. I'll talk to you, and Chava may well have spoken about some of this, about the brain development research that says what happens in the first 3 years of life or 5 years of life has lifelong consequences, that the child's brain in those early years is exquisitely sensitive to the environment, whether it's nutrition, whether it's stimulation, whether it's stress, etc. And then all of these things together, the brain development, the case for early intervention, the life course research, makes it very important, not just in this country, but in other countries as well, that we approach children in a very different way. So we really do need new service delivery models. And, you're the forerunners of this. When you go back to your practices and begin to implement this knowledge, you're truly the chalutzim. So I trained in Boston, and the chairman of the Department of Pediatrics at Harvard, in the first 6 months that I was there, once gave a talk. And this is what he said, that most hospital pediatric admissions represent a failure of the healthcare system. So this has been a major principle, if you like, for my whole career and the development of my department back in Australia. So this leads to two additional questions. What went wrong in the community that this child needed to have tertiary care? What went wrong in terms of the community services this child needed to end up with specialist care? Then there's another question. How can we be working with parents and other professionals to prevent illness and injury? And that's a theme for you. How can you be working with parents and with some of your colleagues and allied health professionals to stop children going to hospital, to stop them needing tertiary care? So conceptually, I would say that the health system has changed over the last 50 years or so. So the first era, I say, was yesterday, and this was a very simple conceptualization of health and illness. And it's best exemplified by the example of infectious disease. Children got an infection, they got sick, They were treated by doctors and they got better. Very, very simple cause and effect. And when you think about how healthcare systems are organised, think about your practice in the health funds, it's still largely like this. A child gets an infection, gets gastro, gets a sore throat, whatever, comes to a doctor, you treat them, you write out a prescription, and you send them away. Okay? But that was yesterday, and it was centred really around doctors. Today we're in this, what we call the second era, and suddenly care is much more complex because we're seeing children with chronic illness. We're seeing children survive with conditions that they would have passed away years ago. We're seeing the advances in medical care now give rise to a whole cohort of children that have complex sorts of conditions. We're seeing premature infants who would have died 30 years ago now surviving with a whole lot of issues around their development and behaviour and so on. So we're seeing real subspecialisation. You go into the hospitals now, they're totally unrecognisable from when I trained in terms of the technology, in terms of the understanding of genetics and the biology and so on. But it's now multidisciplinary, so very few doctors would argue that we can provide healthcare just by ourselves, that we really do have to be working with other allied health professionals, with speech pathologists, with social workers, with psychologists, with school teachers. So when I went to medical school, our relationships were with radiologists, biochemists, pathologists, haematologists. Nobody taught us how to communicate with all of those allied health professionals. But I would argue today they're the sort of relationships that we have to develop. So in the community, we need to know where the speech pathologists are. We need to be able to refer easily to a psychologist or to a social worker. So we're in the middle of this. This is going to continue to be very, very important in healthcare. But it's now been overtaken by what we call the third era. And that is not just treating disease, but optimising health for all children. Not just those that come to your surgery, not just those that go to hospital outpatient departments, but indeed our interest is on all children. So that really makes us think about population-based prevention. We're trying to prevent illness, to prevent injury, and it extends well beyond the health system. So you think of the first model, cause and effect, doctors treat, they get better. This is really about doctors being part of the team, often leading the team, because you're the people that the children come to in the first 3 years of life. They don't go to preschool until 3 or 4, they don't go to school. So the health profession, doctors and nurses, are in the ideal position to pick up these children at a very early stage. But it's got to be part of a whole team. As I said before, working with psychologists, with social workers, with speech pathologists, with the people in your community. And these are the underpinnings of this third era. And I'd like to now just go through each of these 4 areas in a bit more detail. One is the ecological model of health and development, which says the environment is a very important contributor to a children's health. This goes well beyond the biological model of infection, disease, doctor treatment. Secondly, changing morbidity patterns. We're seeing a different profile of health problems in children. We're seeing developmental and behavioural and psychosocial problems. So Haggerty called this 30, 40 years ago the new morbidity in children's health, except it's not new anymore. It's been around for a long time. And these are problems such as ADHD, obesity, learning problems, the sort of things that I know you've covered in your course over the past year. The new knowledge about, the new research about brain development in the life course, and I'll show you some of that. And then finally, and very importantly, not just in Israel, but in Australia and every other country that I've been in, the social gradient in children's health. So if you grow up in a disadvantaged environment, you're so much more likely to have problems right across a range of conditions than if you grow up in a middle-class environment. So let's go through these systematically. First of all, the environment for a child is very important. Not just the immediate family constellation, not just the parents, but also siblings, preschools, schools, the community, the region, etc., etc. So when government sets policy, for example, they build a new road through a community, they do it for very good reasons, but that road might disrupt a community. Children may have to cross that road to get to school, for example. So often there are unintended consequences of decisions that are made with good intentions. A common example in Australia, I don't know how common it is in Israel, is a company will sack 100 workers and their share price goes up because business people think, oh, they've become very efficient now. But the 100 people they sack are parents and grandparents, and they go take that stress back to back to the communities, back to their families, back to their children. So the environment in which a child lives is a very important contributor to development. And this is Bob Haggerty again. Health is affected by environmental and social processes as well as both sociological factors. The community in which a child lives is a major determinant of his health. We'll come back and talk about this some more. And this is an article that was published a number of years ago in Pediatrics. This is an American study, and Larson looked at the relationship between social risk factors and health problems. So these are the social risk factors. You would have all of these, except probably black Hispanic and probably uninsured. You could add to this Haredim or Arab populations. These are very common intuitive risk factors. So look at the relationship between the number of risk factors and being overweight. The more social risk factors you had, the more chance you had of being obese. The relationship between social risk factors and social emotional problems. This has nothing to do with biology. This is just environment. Social risk factors and poor teeth. And then finally, social risk factors and poor general health. And this has been replicated in many, many studies. We've known for a long time that social risk factors, the environment, is a major contributor to children's health problems, developmental problems, psychosocial problems. The changing morbidity patterns, you're seeing this in Israel as well. Every Western country, and indeed countries that were low income and now in transitions, like China, like Brazil, are seeing major increases in children presenting with these conditions. I just want to show you some data from Australia. This is the longitudinal study of Australian children looking at behaviour problems with the Strengths and Difficulties questionnaire. It's a standard, commonly used questionnaire. Look how common these problems are. This is a study that was done a while ago. It's now being planned to be repeated next year using a reliable questionnaire methodology. These are the children with diagnosable mental health problems, 15%. So where will we ever get the mental health professionals to treat these children? And then finally, obesity. Just in my state in Victoria, look at these numbers of children that are obese. And you know that there's no effective treatment for obesity. If you go into a bookstore, there's 100 different books, diet books on obesity. And the reason there's 100 different diet books is none of them work. If there was an effective treatment, there'd be one book. So there's no way we can, even if there was a successful treatment, there's no way we can have the health professionals or the hospital beds or the surgery to treat all of these children. And then finally, this is a population study that we've done in Australia where teachers fill out a questionnaire on health and development in the first year of a child's formal schooling. So we have data now on 98% of all children in the country. And so in Australia, a first world country, very prosperous, wealthy country, 1 in 4 children start school developmentally vulnerable. 1 in 4. It's extraordinary, isn't it? And if we did a similar survey in Israel, I suspect it would not be all that much different here either. Okay, so these are different morbidity patterns that we've seen in the past. These are largely not biological causes. This represents the new morbidity, which says to us, says to me, and says to you, and says to policymakers, we can't go on delivering health services the way we did 20, 30, 40, 50 years ago. If we really want to make a difference to the lives of children, and that's why we did paediatrics in the first place, we have to start thinking a little bit differently about how we deliver these sorts of services. The third area is what I call startling knowledge that's emerged in the last 10, 15 years about brain development. So intuitively, we always knew that the early years are important. But the research that's really emerging now is really quite startling. And you cannot be exposed to this research, whether you're a policymaker or a professional, and just continue business as usual. So this is the new knowledge. First of all, the science tells us very clearly that the early years of a child's life are critical in shaping a child's future learning and behaviour. This is non-contested research. It's black and white. Secondly, the life course research, and I'll show you some examples. What happens in those early years influences adult outcomes. And then for many children, the trajectory is set in those early years, the first 5 years. So for so many children, by the time they start school, they're on a trajectory either to success in life or having problems in life. Okay, and it gets harder and harder as children get older, as I'll show you, to change that trajectory. If we really want to make a difference to these kids and to adolescents and to adults, it's the first 5 years before a child goes to school that are so critical. And this is what the science tells us, that the brain architecture, and you've probably covered a lot of this, haven't you? Doesn't hurt to reinforce. The brain architecture and skills are built in a very rigid, hierarchical fashion. So the genes, the DNA, is the manual of development. But the way that unfolds depends on the environment. And the foundations that are built in those early years are very, very important. And the analogy we use is like the foundations of a house. If we take care with the foundations of a house and it's solid, then everything that we build above that is probably going to be okay. But if the foundations of a house are not solid, because we took shortcuts, we wanted it cheaper, or we used second-hand materials, everything that follows subsequently is potentially at risk. So we can go back later on and try and repair the foundations, but it's complicated and it's difficult, and it'll never be as good as if we would have got it right the first time. And what happens over time is the plasticity of the brain decreases. The brain becomes harder and harder to alter as you get older. Now, it's not all finished by the time children start school. I'm not trying to give you that impression, because the brain is a learning machine. We continue to learn right through life. The brain is always refashioning itself. But any of us that have tried to pick up a language as an adult, like my Ivrit, or to learn a musical instrument or play a sport, it's difficult if you're an adult, because the plasticity of the brain decreases. It's harder and harder to change. So the research is very clear that biologically and economically, it's far more efficient to get it right the first time than to go back later on and try and fix things up. And that's the whole rationale for prevention and for early intervention. And what's really critically important is the quality of the relationships that a young child has with the caregivers. It's not the fancy toys they have. It's not all the learning videos that they can buy in the stores, etc., etc. It's the relationship that a young child has with parents, with caregivers in early childhood centres, etc., etc. And when those relationships are dysfunctional, when those relationships are suboptimal for reasons that I'll show you in a moment, that interferes with optimal brain development because of stress. So we conceptualize stress. We've really learned the importance of stress, the absence or the presence of stress in a young child's life. So you can't eliminate stress completely. So there's this notion of positive stress. And this is the stress that a young child feels when they feel pain, when they feel the pain of immunisation, or when they fall over and hurt themselves, or when they have a temper tantrum because the parents won't give them the dessert until they finish their vegetables. the stress is short-lived. So hormones go up, stress hormones go up, cortisol levels go up, but they come down very quickly. And this is part and parcel of growing up. And the reason that it doesn't harm children, the reason that it doesn't persist, is the presence in that child's life of an adult who makes it okay. So when a baby cries, the first thing you do, you pick them up and you cuddle them. When you take a child to be immunised, they sit on the parent's knee. When they start to cry, they're there, it's okay. So a parent makes it okay. This is predictable, it's normal, it's part and parcel of life. There's this notion of what we call tolerable stress. Tolerable stress is not predictable. This is the stress that a young child feels when they go to hospital, when they're in an accident, when there's the death of a loved one in the family, when there's separation of a family, when they lose a parent, they lose a pet, or when there's natural disasters like a bushfire. So you would see this a lot in Israel, unfortunately, particularly in the south. These unpredictable events like missiles and shells, etc., etc. Stress levels go up, cortisol levels go up in the child's brain, but they come down again. And they come down because the event may stop, but they come down because there's somebody in that child's life who makes it okay. And if you talk to the people in United Nations who fly into disaster zones and fly into war zones, they'll tell you that the best way to make sure the kids are okay is to make sure the parents are okay. If the parents are okay, they will look after the kids. What's not okay is what we call toxic stress. This is where there's prolonged stress in the child's environment, there's prolonged activation of the stress response, high persistent cortisol levels, and where they are persistently high, the research is very clear that interferes very significantly with development. And we see this in extreme poverty, in physical abuse or sexual abuse, in exposure to family violence, where parents have mental health problems, where they have substance abuse. It's a very stressful caretaking environment all of the time. And this disrupts not just development, but it resets the neuroendocrine axis. It changes the biochemical and hormonal systems. We need oil for that door. It resets the systems and makes them much more vulnerable then for insults later on. So disordered brain circuits lead to problems in children, but importantly, they lead to problems in adults as well. So these are some of the problems you and I see in our practice. And for many of these issues, there's emerging evidence now that it's at least contributed to partly by this environmental stress. Because once we understand the nature of that stress response, it helps us understand why children from abusive environments are so at risk, why children who grow up in extreme poverty are much more likely to start school with problems, etc., etc. But more importantly, there's there's predictors of these issues for adult life. Kaiser Permanente is a health maintenance organisation in America that's been in existence for 30, 40, 50 years. And they keep meticulous health records. This study is a series of studies now where they took adult patients with problems and went back in their lives looking at the histories to test the hypothesis that one of the reasons that they had these problems in adult life is they were exposed to stressful life events earlier on. So they looked at the relationship between being an alcoholic in adult life and the number of adverse childhood events. So you can see the more stressful childhood events they were exposed to, the more likely they were to be an alcoholic. This is the relationship with antidepressant prescriptions. The more of these they had, the more likely they are to be depressed. And then intravenous drug use. So we're seeing this same sort of pattern all of the time. So this is the range of adult mental health problems that may have their roots in those early years. Now, this is not just developmental psychosocial things, mental health problems, illiteracy, etc. There are hardcore biological issues there as well. Heart disease, cardiovascular disease, hypertension, stroke, some cancers now. So the research about this is becoming more and more robust. And the mechanism is probably that stress response, because that resets all of the receptors, the HPA axis, it resets that at a different level and increases the vulnerability of that person to the onset of these sorts of problems later in life. So from a policy point of view, from an advocacy point of view, this has big implications, because what we need to be saying to our adult colleagues is, if you really care about improving outcomes in adult life, it's too late to wait until these problems emerge. You really have to invest more in children. So as I said, any sort of adversity that impacts on the parents has that capacity or the potential to have a negative impact on development. And these are the sort of changes. We can actually see DNA changes to chromosome material. And the late Clyde Hertzman has coined this term, the biological embedding of environmental events. So you see the extreme dysfunctional situation in one generation. By the next generation or the generation after that, it becomes part of the genetic material. And then you see this intragenerational cycle of these sorts of problems. And then finally, the social gradient in health. And I know you have that in Israel. We have it in Australia. It's really present in every single country. So children who grow up in a disadvantaged environment, almost inevitably, as a group, we're not talking about individual children, are at risk of having poorer outcomes. So I'm going to show you some Australian data as well. This social gradient begins during pregnancy, before the child is even born. So this is the relationship. I'll just come and point this out. You can see in Australia, this is women who smoke during pregnancy. SES is socioeconomic status. Low SES compared to high SES, and Indigenous compared to non-Indigenous. So we have major health issues with our Aboriginal population. And here, very similar pattern for low birth weight. So even antenatally, we're starting to see this social gradient where children from a disadvantaged, women from a disadvantaged background are already looking different from women from a middle-class environment. And then when they get to preschool, that's even more pronounced. These are American data from a Hart and Risley longitudinal study. You can see children start their language with around about the same potential, even allowing for individual differences. But look at, by the age of 3, children from a low SES background compared to high SES in terms of their vocabulary. And the brain development research tells us that these trajectories don't close. They become more and more entrenched as children get older, harder and harder to change. And these are Australian data I want to show you now. This is from the longitudinal study of Australian children, where we're following up cohorts of children from a very early age. Look, by the age of 2, we're seeing differences in social emotional issues between advantage and disadvantage. They become more pronounced. We see it for communication skills. We see it for vocabulary. Look how they start to separate now. The trajectory is becoming more and more fixed. We're seeing it for emergent literacy. And then school entry, this is the ADI that I mentioned to you, where teachers complete this questionnaire when the children start school. 1 in 4 children arrive at school already in trouble. Look at these social differences. So if you come from a disadvantaged environment, the most disadvantaged, look at this gradient. You've got a significantly increased chance of arriving at school already in trouble. So how do we make a difference? Well, we address the risk factors and emerging difficulties before they become entrenched. At the earliest opportunity, we try and prevent these occurring in the first place, but when problems start to emerge, the challenge is to detect them at the earliest possible opportunity and do something about it. And that's the opportunity that we have as paediatricians. That's the opportunity you have, because as I said before, it's the health professionals that are seeing these children and families from birth. It's not teachers, it's not psychologists, it's not social workers. It's the paediatricians and the nurses that are making contact. So the opportunities for you to make a difference to the lives of these children are just profound. The earlier we do this, the better. I said before, I don't want you to leave here thinking it's all over by 3 or by 5, but the brain development research tells us the earlier we begin, the more impact we have, as represented by this graph here. If we start very early in the piece, then the cost of intervention is low and the effectiveness is high. The longer we wait, the cost goes up and the effectiveness goes down. And in most countries, including Israel, we wait until problems become so entrenched that we have to acknowledge them. We can't ignore them anymore. And then we throw money at it. But at a population level, it's bad policy. From an economic point of view, it's bad policy. So we really need to move as a profession from individual reactive. We sit and we wait in our offices until children come to us with problems and then we treat them. But there's a real leadership role for health in prevention at a population level, of taking the lead, working with other people, not just to be passive and treat children when they arrive, but to be active in promoting the health of all of these children. So the role of the paediatrician, I've just written some things there, is in prevention. So give me some examples of prevention. Immunisation. This is a test for what you've learned in the last 12 months. Yeah, measuring weight, monitoring weight. Yep. Yep, reassurance. Yep, what else? Sorry? Sorry, I can't hear. Yep. Reading to young children. Okay, so that's good. Early identification. How do you identify problems early? Correct. You say, do you have any concerns? It can be as simple as that. Are you worried about your child? Do you have any concerns? And you can use developmental screening tests. I'm sure you've done that. Okay. So, or you know the family from a previous sibling, so you know that something has happened, like the family split up or the father's lost his job or something. So you can identify risk factors. Remember, you're the paediatricians are the people seeing these families over time. You can see where things start to change, where family circumstances change. So families that weren't at risk suddenly may become at risk because of family circumstances. Once you identify issues, what do? You either manage them yourself or you refer to somebody else, right? So have you got well-established referral pathways? So in order to do that, I would argue you need to map the resources. That every professional, every paediatrician, every practice needs to systematically map who are the speech pathologists, where do they work, who are the psychologists, who are the social workers. And you need to establish a relationship with them. So it doesn't necessarily have to be a formal referral. You might just pick up the phone and say, look, I've got a child here, a family here, what do you suggest? But unless you know where those people are, it becomes very, very difficult to do. Follow-up is very important, closing the loop. So just because you identify problems and just because you refer, your work is half done. Because one of the risks is that parents don't follow your recommendation. That we know there are many, many barriers to services. It may be too far, it may be too expensive, there may be cultural gaps, there may be no transport, nobody to look after the other children, etc., etc. So part of our responsibility in early identification and referral is closing the loop, making sure that parents keep the appointment with a speech pathologist or keep the appointment with a social worker. I've said before about working with other professionals. Nobody taught me that in medical school. The relationships that we had, the people we worked with were radiologists, biochemists, etc. So we had to learn a whole new way of communicating with other professionals. And then finally, the paediatrician as a community advocate. Paediatricians, are you respected here in the community? You know, in our country...
Not as much as in Australia.
No? Because you're dealing with Jewish patients, that's why. But in Australia... But don't underestimate the influence you have. You know, in our country, doctors still, if they do surveys in Australia, and the medical profession as a profession is not highly regarded, but families like their own doctor. You know, there's that difference. And so don't underestimate how much influence you can have as a paediatrician who cares about the health of all children. And there are dozens of advocacy issues, from safety, a school crossing, busy roads, etc., playground, etc., etc. So, in summary, I think developmental behavioural paediatrics reflects the child health issues of the time. We're moving beyond this first era where we simply treat disease towards addressing what children and families need now. The science of early childhood development speaks for a very important role for paediatricians. And as I've said 2 or 3 times before, you're the people that see these children from birth. You're in an ideal situation to see the risk factors, to identify those problems very early on and make something different. And this is why you're the chalotzim. I think the training, what we'd like to see, what I'd like to see as an outsider, I'm sure what Chav would like to see, is that everybody, every paediatrician gets training in developmental and behavioural paediatrics. So the aim is to, if we did nothing at all, we know that many children's development would sort of fall away. What we really want is every child to fulfil his or her potential. Current practice is probably here, at least in our country. There's lots of good programs. NGOs are working in this area. You're doing some good work. We're doing some good work, etc. But there's a big gap there. We know enough now, in theory, to lift children from that red line to the green line. And this is the opportunity we have. The science is there. What we really need to do is to start to change our practice and develop the systems of delivery to help us implement that knowledge, to bring all our children to that green line. Happy to answer any questions. You've heard all this before during the year, huh? Oh, yeah. Ask me a question, Jacob. Yeah.
You managed to show that you can change it in an area that you put the right resources and the right pediatrician that would...
We're starting to. In our centre, we don't do any direct service delivery. We see patients in our centre, and our trainees go out into the community and see patients there, but we are not responsible for community services. What we do is to develop the tools that people like you and communities use. So we're doing a lot of work with communities around mapping services, doing training, developing different service models, much more integrated models where paediatricians work much more closely with allied health professionals, etc. So the research is emerging, but we don't have hard data yet. And one of the reasons that we don't have it is it's almost impossible to demonstrate in a community that this made a difference, because there are so many variables that affect development. If we look at program logic, our research does show that we have better access, that families have better access, they're more satisfied with work, that health professionals can refer more easily because they've mapped surfaces, etc., etc. Sure. You follow the American system.
The new babies come with the genetic chip counseling, and you can say, okay, there can be a problem at the future, but what can we do now? And they start to come with duplication of chromosome 16, and and part of it, yeah, and
Only Q20.
you don't know what to do with it.
What?
They also don't know what to say.
You know, in our country, the science is way ahead of the ethics. You know, the ethics is not keeping up with the science. Not in my lifetime or your lifetime will genetics solve all of these issues. I promise you. And so it's a really challenging question. You know, in our country, it's not that common that parents come to us with gene profiles and things. Really?
It's becoming very common. Unbelievable.
So you know what I would do? I would say, "Ani lo yodea."
So they send the parents for a genetic chip to see if the parents have it.
And they have it.
And did the health funds pay for that? Well, I think... Who recommends it? Wow.
And it's very Jewish to do it, because you want to know everything about prevention.
I honestly don't know what I'd do. You know, I think... That's what I was saying. I think those debates haven't been had yet. You know, the science is moving ahead of genetics, ahead of our understanding of what to do.
I believe that the whole specialty of
Shh.
Yep. Medicine should change, and I hope they'll change it in the next few years, not decades, but the next few years, because you told us that today, if a child comes to the hospital, it means that something's wrong with the service education unit.
Mm-hmm.
And a lot of us, we finished our specialty a few years ago,
Mm-hmm.
and the specialty, like the way it's built today, it's not community oriented.
Mm-hmm.
You have very, very few tools that you get from the specialty that help you.
Sure.
That help you later as a physician.
Yep.
And I really, really hope that in the near future, someone will understand that what a doctor needs later, the nutrition in the community needs later, is very different than what he is getting now.
Yep. So that's the... Sorry, go on.
And maybe Chava will change it.
Not alone, I'm not alone.
But you
I hope that there will be a specialty,
But here I have a whole class of GIs.
not the way it's today. Because
Yeah.
if specialists control the hospital,
Yeah.
someone like me that decides in a very early age that what he wants to do in the future is work in the community needs to get an education that is community oriented.
Sure.
To know more, not now after a few years.
Did you ask her to say that? That's music for your ears.
We do have a
I
new
know
head
it
of
for I know it for a long time that what I got in the hospital is good.
Okay, so let me...
I'm glad to know all these things.
So
but
let-
it doesn't help me when I work.
In Australia now, you cannot become a paediatrician unless you've spent a minimum of 6 months in the community.
It is what it's the same. You have 6 months.
Yeah, but everyone ignores it.
סליחה, וגם כשהם באים הם יום אחרי תורנות, שבת אחרי תורנות, הם נמצאים יומיים בשבוע, זה הרבה.
וגם אף אחד
In
לא
my
קונה
book,
אותם.
you have to do 2 years of hospital just to be acquainted with most of the things that you see in hospital.
There is a new...
And most of the specialties you decide at an early stage that is what you want
Sure.
to do needs to be in the community.
Sure.
There is a new head for the medical council, למועצה המדעית. So we hope that maybe we will be able to convince him.
גידי פרק.
Do you know what helped change things in this? Can I just... Check it. One of the things that helped change things in Australia is that I did a survey of all the paediatricians who said exactly what you said, that they identified a big gap between their training and their practice. And then our College of Paediatrics, which does the exams, took note of that. And we've spoken about this before, about surveying paediatricians to see whether is this just what you think and a few people here think, or is it common knowledge? Because without data, no one, no data, no problem, no solution. So it's really important to get that sort of data. But that's my wish as well, and that's the whole rationale for why you're here doing this course. That's why Chava came to Australia. There was a question over here first.
We're seeing increasing number of children, age 12, 13, 14, abusing alcohol.
Yeah.
Abusing alcohol intoxication.
It's so not a Jewish thing, is it?
Only the kids, yeah. But
Yeah.
Do you know any programs, community programs to
In Israel, in Israel, I don't, but it's a bit. No. Not so young. Unless I'm naive, I don't think it's 11, 12. It's a bit older, 14, 15, 16. But it's very, very common towards the end of high school. We call it binge drinking. You know, they just go to get drunk, and it's a huge, huge problem. And then they get drunk. They have injuries. They have violence. They have sexually transmitted. You know, all these things. So it's a huge problem for our adolescent colleagues. But then it goes back to parents as well about supervision. Do you want to tell the story of your daughter, the 10-year-old who wanted to go to the mall by herself? In the end, it's a parental responsibility, and so that's part of prevention. You know, I guess it's part of our role as paediatricians to have these conversations with parents. In the same way as we have developmental milestones at 2, 3, 4, 5, as parents, as their children are getting close to adolescence, maybe it's our responsibility to say, here are some issues you need to be thinking about. You know, screen time, independence, injury, drinking, etc., etc.
This is when the become very of Mohammed will get to 10 years old.
Correct. Yeah.
That's the issue of the 10-year-old business.
We're leading. Israel is leading at the age of 12, 13.
Wow. That's
So maybe we really, I mean, apparently there's big discrepancies in different parts of the country. It's really not an issue.
Shh.
I just wanted to point out that it's an incredibly important lecture, but it kind of beats the point, because what we need is education, to educate people,
Yeah.
and we need finance for that.
Yeah.
So we're not the people.
Yeah. Well, that's why what Milchedet, this is not an advertisement for Milchedet, but I think that this is the first sign of a health insurance system starting to change the way we do things. It's a small step, but I'm hopeful that everybody will follow. So, you know, Rome wasn't changed in a day. This is not going to be all changed. But what you're saying, and I totally agree, the system has to change. That
it's not just the health system, because it's combined with the education system and
Sure.
whatever, because where do we draw the line
Sure.
between the medicine
Absolutely.
and everything? Because
Totally agree.
first
Yeah.
of all, we are capable of doing some things, regardless of the time and the money and whatever.
Yep.
Our knowledge is limited, and even not the community welfare of children.
Sure.
So we should be like more general.
I totally agree. And that's the other area that we work in Australia that maybe Chava can talk to you about sometime is what we call translation and promotion. So we have these national CME programs for childcare workers, for community nurses, for policymakers. Chava, maybe you can give them our website and you can have a look at our website. So we have all of these vehicles. But there's a quote that I sometimes use in the slide. The first thing is to make people dream. You know, if you can make people dream about this thing, then that's the first step. But look, it's not going to change. It's terrific you're here. You've been here all year. But it's going to take a lot more than just you people undergoing training. I totally agree with you. But Chava's going to do all of that.
About our training, which is definitely not, I mean, in the amount of specializing in pediatrics, what about textbook art? Is that developing also? Like, I don't know if one, maybe I just don't know, probably I just don't know. A pediatric community textbook or a few textbooks.
Sure.
Are there good ones?
When was the last time you bought a textbook?
No, it's not true.
You're talking about information
No, I do read the textbook. If you want a basic training, then it can't be that I always go and read. I mean, I do read up to date or whatever more often.
Sure.
But if I would have a textbook, then it would make a difference. I do go back to basics.
We did put on the website of the Pediatric at least 3 different textbooks on community pediatrics.
So can you recommend?
One of Barry Zuckerman, there's one from Mary Woodall, and there's another one that I can't remember his name.
That are general pediatric community?
Yes. So they are in the website. There are 3 recommendations of textbooks.
Just one comment. I think that we try to define from the beginning, the whole field of pediatrics, or community pediatrics. And it's not only knowledge. I think it's even the personality of the
Chava, shh. Check it.
It's the way we deal with children. The time we spend with each other, and also the personality, because what we're doing now is health care much more, is mental health care more than physical health care. It does fit everybody as before. Many people go to med school thinking about physical health.
Yep.
And moving to mental health, which is much more common now, doesn't fit everybody.
I agree.
I think it's very important to understand that.
I totally agree.
Spend time. It's changing many things in the personality before you can do that.
Yeah, I totally agree. It's like research. Not everyone can do research. I think it's horses for courses. You can't expect everybody to do this, but there's enough interest, I think, that people, if they're given the chance to practice in a different way, will do it, provided the systems support them to do that. Some people are just interested in... some residents come to me for career advice, and I say, are you interested in just science, or are you interested in people? If you're interested just in science, go and do nephrology or hematology. If you're interested in people, then do community pediatrics. So you have to fit the temperament of the person, as you say, to the area of practice.
Do you have a national web-based parent education program?
Yeah. It's...
Because here we have the frustration that you have to educate the parents, and you have to repeat yourself every time.
Sure.
If you could have sent them to see a video or something, or something to show them, and even to give them a book when the baby is born, or a CD or something.
Sure.
Raising children
So we have a government funded website called raisingchildren.net.au. Everything on there is peer reviewed, and it's a one-stop shop for health, development, behaviour. It's got baby karaoke on it, because when we did the research, parents said they like to sing to their children. They don't know the words, so you can hook on that. Ba ba, you know. It's in English, but many of your patients speak English, so please use it. There's a whole section called Parenting in Pictures for illiterate parents, and that's downloaded very frequently by health providers. They print out the pictures and hand that to the parents. So it's my legacy thing. I'm very proud of it. But please use it. Raisingchildren.net.au. Can you circulate the website? Yeah. Yep.
Are we allowed to translate and use it for our patients? Is there anything limiting us?
You can use it any way you want. It's a pub. It's a
national thing, a free thing.
Yeah.
Free officially.
Yeah. It has milk. Yaakov. Shalom Aleichem. You on now? I'm done. Take one piece, yeah. Okay.